Cytology.
Yay. Okay, so this is obvious. So this is a CT-guided fine needle aspirate from a lung nodule. The nodule is a very well circumscribed, 1.5 centimeters in size. And this lesion was positive for synaptophysin and chromogranin and had a Ki67 of essentially 0. Okay. All right. So that's essentially what I wanted to show, that you can have a carcinoid tumor of the lung can have a spindly, or just a slightly spindly cytology and very bland looking cells. But obviously the reason I gave the Ki67 is because if you had this in real life, you would be thinking, could this be small cell carcinoma? Other things would be in the differential. But once you have come into the neuroendocrine realm, then the only thing that really matters after that is how proliferative is it, how mitotically active.
Yeah.
And although I don't use the Ki67, many people like to use it. And as Natasha Reckman presented at USCAP just a couple of days ago, now they're beginning to say that Ki67 is desirable in these lesions.
Yeah, I think it's really helpful in these cases where you don't see mitoses or necrosis, right? Because I think you have to be really careful if you don't see those in diagnosing neuroendocrine tumors, right? That you don't overcall a carcinoid.
Yeah.
I had that experience, a very crushed thing that looked like a small cell, and you did do the Ki67 and you find it's very low and it helps you.
Yeah.
But sometimes I want to have the criteria to separate a typical carcinoid from typical carcinoid, and so I want to find the mitosis, and then the Ki67, you find that 10 Ki67. What should I do with that? If I don't find, I count the mites one time, another time, and I find only 1 or 0, I still calling it typical. But I have a slightly high Ki67.
That's the problem. That is the problem with Ki67, is that when you have an entity that's defined by mitoses, not by the Ki67, that the Ki67 becomes irrelevant. Like if you have, for example, a bland looking carcinoid tumor with no mitoses and no necrosis, what do you do if a Ki67 is 80%? Yeah. You cannot call it small cell carcinoma on that basis. So that's why it's tricky. But I do understand the argument about using it on small crushed specimens. But I think that the use of Ki67 comes with its own pitfalls.
Agree.
Yeah. All right. So carcinoid tumor, that's number 1. Let's go to number 2. So this patient, let's create a stem here. What should I make it? Should I make it easy or hard? Okay, let's make it easy. This patient is a 60-something-year-old, whatever, man with a history of a salivary gland tumor and now multiple lung nodules. On the stains, this had a two-cell population on the immunostains. All right, guys, are you ready with something? Adenoid cystic. Okay, guys, you got it. It's much harder if I don't give the salivary gland history, because of course you know that primary lung adenoid cystic carcinomas also exist, and of course that becomes harder. But I thought that the pattern here is pretty good.
Agree.
You guys want to say why you called it adenoid cystic? What made you go there?
So to me, like I think there's some areas that you see these kind of more punched out spaces in there. Some of them are a little bit more challenging because they're a bit larger, right? But I think that and the kind of the architecture of this, and it looks like more of a central lesion.
Yeah. there's a nerve with a perineural invasion around it, right?
Oh, yeah.
I haven't seen a lung adenocarcinoma, a normal lung adenocarcinoma looking like that.
No.
Yes, that's true. Very, very unusual it would be to have that kind of look. Yeah.
I think adenoid kystic is not that difficult to, but I have problems with mucoepidermoid always.
Yes.
Because it has this scamoid appearance, and it's like, is it not? I find it really hard.
Can be hard.
Agree.
That's true. One thing I really find helps with mucoepidermoid is true mucoepidermoid of the lung is almost always happens in young people, you know, very young or 20s, 30s. Outside of that, it's almost never mucoepidermoid carcinoma. All right, let's do another cytology case.
He wants to kill us today.
I know.
He said, have you paid attention to my correlation session in USCAP or not?
This patient has a pet bird. No, I'm just. This patient has numerous bilateral lung nodules, and she is 59 years old with numerous bilateral lung nodules. There is a history of a malignancy somewhere, a carcinoma. Where? What is the most likely primary site with this morphology? This is something that cytologists have a name for. This is a classic finding. Do you know? This is also, I put this because the board exams, I mean, I can't tell you how many times in my residency I've had this question. Residency days.
I'm not sure.
Metastasis to the lung, primary somewhere, female patient. Shame on me.
Is it metastatic breast? I don't know.
No idea. I have no idea.
Breast. Of course, of course, it's not specific for breast to see this, but they call it in the cytology world cannonballs. Cannonballs. And the cannonballs are supposed to be like a marker of metastatic breast cancer, like a morphologic feature of metastatic breast cancer on cytology.
Cool.
I was thinking in a meatball.
What's that, Irene?
In a meatball, like spaghetti with meatballs.
Delicious.
That's spaghetti and meatballs, and that comes into play in pap smears, but we'll come to that some other day. Okay, breast cancer. All right. So this is not a spotter because clearly it's not easy enough
I'm sure it's a spotter for cytologists.
Yeah. Okay. Let's go to another one. This is interesting. I think I have actually seen it once in some sort of exam. So this is a 32-year-old IV drug abuser with a very, very low CD4 count and very sick, is losing weight, has fever, and an aspirate of the lung shows this. This is a Diffquick stain. Shows this image. Patient was tested and on laboratory testing was found to be HIV positive. What are we seeing here? What is the diagnosis from this? Again, this is cytology trivia, so sorry to dump it on you guys.
I don't know.
We have to learn. You are making me study. I'm going to study cytology after that.
Yeah, I don't know, Sanjay.
Okay, guys.
Canada?
I'll tell you, this is on the Diffquick. These things are called negative images.
Oh, yeah.
See these unstained things?
Yeah.
If you do an AFB, these are all mycobacteria.
Oh.
Yeah, so each of these unstained, like rod-shaped.
Yeah.
So if I should have brought the AFB also, but that would be too easy.
Yeah.
So if you do an AFB on this, it is like loaded with
cool.
So this is the classic, MAI in a AIDS patient.
Cool.
It looks like this on the Diffquick stain. So that's like a clue to do the AFB stain.
Cool.
Okay, not a spot. Okay, not a spot. All right, I really shouldn't be.
It's the revenge of the cytology.
I know.
Oh my God, I don't even know what to say here. Okay, let's make this. This is a pleural fluid.
The thing is getting worse. The pleural fluid.
Getting harder and harder. This is a pleural fluid, and
two populations.
the patient is a is
I
an
see two populations.
man with exposure and a unilateral pleural effusion. There is no parenchymal lung mass, and these cells stain for calretinine and have lost pathway.
There we go.
He's showing us the window now. I
Yeah.
see the window.
I see the frilly skirt here of the mesothelial cells.
Actually, once you know that BAP1 is lost, the frilly skirt becomes more easy to see. This is known as immunohistochemistry aided morphology.
Yes.
Okay, guys, what's your diagnosis?
Well, I would suspicious for mesothelioma. I don't know how far you go on cytology with BAP1 loss.
Yeah.
Like I think that depends. Are people going out right to malignant if there's BAP1 loss?
Yeah, well, some would, I think some would, and some would say suspicious. But in the old days, the teaching was that mesothelioma clusters are larger, have more numerous cells than reactive mesothelial cell clusters. And cytologists generally said that we don't trust that enough to give a definitive diagnosis of mesothelioma. Now I'll tell you that there were people, I have seen cytopathologists, some senior and very good cytopathologists who will actually call mesothelioma. If the setting is right, the thing stains as mesothelium and shows this morphology. But I think most cytopathologists are not that brave. They will not go that far. But with BAP1, I think some people will. So if you show that this is BAP1 lost, they will call this mesothelioma.
It'd be interesting to see how things change now that there's going to be a recognized mesothelioma in situ entity. For do you need to stain every pleural effusion now for BAP1 loss, right? Right? Because every patient who has a unilateral pleural effusion, how do you know it's not mesothelioma in situ, right?
Oh my God, yeah, I didn't even think of it that way. Yeah, right. I hope that this thing... I always assume that mesothelioma in situ is a diagnosis that covers the mesothelioma experts if they diagnose mesothelioma and then nothing shows up on the extrapleural pneumonectomy. Then you can say, well, there's no mass, but this could have been mesothelioma in situ. But no, clearly there must be rare cases that fulfill the criteria. But I think for residents and people starting off, that's a very, very bad thing to be thinking about. You should be concentrating on general principles in mesothelioma.
I agree.
You need masses on the pleura. All right, so let's go to the next.
Is the little group is reactive or both are malignant?
See, I think that everything here, not everything, I think like this one is benign. That's probably a macrophage. And certainly these are all
malignant.
That one, I'm not sure. That's a very good point, Irene. I see your two population thing, because typically two population things are adenocarcinoma, right? That's really the training. If there's so I honestly, I don't know what that is. I don't know.
Because before you said that, I was thinking this was an adenocarcinoma, because when I see pleural biopsies, and when this group looks really ugly to my eye, the big one, and when you see an ugly neoplasm, you think more about adenocarcinoma with the nucleoli and so. But here, I see cytology is a bit different.
Yes. No, okay, this is definitely not a spotter. I mean, the thing that expert cytopathologists can't comment on is definitely not a spotter so apologize for that. Okay, this one is a spotter, so bear with me here. This patient was incidentally found to have how big is this? Let's see, about 3 centimeters, right? About 3 centimeter nodule on the surface of the lung, attached to the pleura. So there's a solitary mass on the surface of the lung. And on the top right, you can see the histology. What stain do you want to see to immunostain to establish the diagnosis here with?
Stat 6.
Correct. Stat 6. So this is a solitary fibrous tumor. Matt, do you agree? Would that be reasonable as a spotter?
Yeah, no, definitely. Yeah, I think the other thing you might see is the vasculature, right? The staghorn type vessels in if you were looking for a spot diagnosis image.
Correct.
Yeah. You have the patternless pattern here, and also the
collagen.
The collagen is very typical.
Yes.
But
I don't like to call this ropey because it takes away the SRIF ropey and puts it here. But it is ropey. It's pretty ropey, this collagen.
But doesn't have the nodes.
It doesn't have that waviness. Some people call it wiry, W-I-R-Y, wiry in between those cells. But I think this combination is very classic. You know, a solitary mass sitting on the pleura, plus this kind of morphology, you know, with the wiry collagen and a spindle. And then if you just have a stat 6 positive, you're done.
Yep.
That would establish it. All right.
This was a spotter.
Moving back to H&E. We're off the cytology, guys. All right. So this patient is a 29-year-old. Oh, well, let's make it 45-year-old. This patient is a 45-year-old man, a smoker who was found to have a bilateral abnormalities on the CT scan that the chest radiologist described as crazy paving. Diagnosis: pulmonary alveolar proteinosis. Congratulations on getting the pulmonary part right.
But I'm not sure until I do a pass.
Yeah.
Not sure till we do a PAS.
They love that. This is an exam question.
Yes.
They always say a pass, and the clinicians remember that from the school, and they ask you, was it pass positive? Because they remember that, and you said, I don't know how to interpret them.
Yeah, you know, if you ask them, well, what would you do if this is PAS negative? Then they're like,
case report, obviously.
Case report.
I just hate when pathologists say this is a slightly past positive, because what is slightly past positive?
Yeah, what isn't slightly PAS positive? Exactly right. Exactly right.
So maybe it's useful for trainees to discuss why this is not PCP, because we saw some examples of pneumocystis, right? And I think that has a similar morphologic appearance.
Or edema.
Yeah.
So that's really the differential. Is this edema, or is this alveolar proteinosis, or is this pneumocystis? So for edema, it looks very, very similar to this, except this is a more like a granular appearance, which you see on the HIMAG. I love this as a clue, as a histological clue, these big chunks of pink material, which are actually bits of surfactant. So these big chunks of pink material, very, very important to tell apart from edema, which it looks all the same throughout. It's all pink. The second thing that helps to tell from edema is the CT scan. I hate to say go back to radiology, but this here it really helps, because if they say crazy paving, you're almost always in the PAP realm. There are only a few other things like exogenous lipoid pneumonia that cause a crazy paving pattern. And then for pneumocystis, as you saw from what both Matt and Irene presented, pneumocystis causes a froth with dots appearance in the alveoli. The interstitium is generally a little bit abnormal. The type 2 pneumocytes in prominent. In PAP, which is what this is, alveolar proteinosis, the interstitium is absolutely normal, which is fascinating because it looks interstitial on the CT, But on histology, the interstitium is absolutely normal and all the abnormalities in the airspace. And if you really are having difficulty between pneumocystis and alveolar proteinosis, just do a GMS and the GMS will be negative here.
Yep.
Is that fair, guys?
Definitely. I think it's
I would
great
add
description.
that it looks like smashed potatoes with little vegetables on it.
Nice.
Mashed potatoes with little vegetables in it.
Little
like it.
pieces of.
Like little mental pictures that were, isn't it? With like the histiocytes in the dark. What was that for LCH? That was for
the histiocytes that kissed in the dark.
yes, those
Histiocytes that kiss in the dark. Yeah. I like it.
All right. Hopefully the residents will never miss this again, alveolar proteinosis. And remember, this is a surfactant clearing problem. Like there's a problem with a mutation, a thing in the GMs, a problem with GM-CSF that prevents clearance of surfactant from the lung, which is what results in this. Okay, guys, great job. This is not quite lung pathology, but I thought I'd throw this in there. Let me give you a stem. This is a 45-year-old woman with lots of autoimmune problems, and anemia, thrombocytopenia, and a big mediastinal mass. Nothing in the lung, just a big mediastinal mass. Flow cytometry was negative. Clonal studies were all negative. There's no evidence of malignancy. But she has these autoimmune problems, anemia, and this mediastinal mass.
Looks like we have some like onion skinning there, right?
Diagnosis.
Oh, what's the... I don't think I've had enough coffee yet this morning, Sanjay. I'm blanking on the name of this, but I know it's got the onion skinning there, and I can see like the lollipop.
Yes.
That's Castleman.
Castleman. I have to say that this is not this is very unfair. Maybe they ask unfair questions in the board.
No, I think this could definitely be a board exam question.
Yes, but they do ask unfair questions like this in the board. And really, in real life, you won't be diagnosing this without sending it to a hematopathologist. Yeah. But Castleman's is actually the right, and you get this onion skin appearance and this sort of lollipop of the little thing coming off to the side. This is not the greatest lollipop because it doesn't have a good stem, but that's what they mean by the lollipop sign. It's just like a funny looking reactive node that might show up on your exams. Characteristically produces a mediastinal mass. Okay, Castleman's disease. Guys, all right, let's go to this one. I think this one is really a spotter.
Oh, yeah, it's my favorite.
So this patient is from lives on a farm and was found to have cysts in his liver and his lungs.
My penis.
All right, we'll wait for Irene's answer.
My pen stopped working. Hydatid?
Yes. Yeah, correct. So both are right. So they've given you two different names of the same thing. One is echinococcosis and the other one is Hydatid cyst. So that's exactly what these are. These are these cysts that have this characteristic laminated cyst wall. So that's the wall of the cyst. And then on the inside of the cyst, you actually get little organisms, little larvae, which are not shown here. But I'll show that at some other time, which are the little, like the viable worm. So together, that stuff is absolutely pathognomonic of echinococcosis. And you'll see
I never had
that here.
This in the lung.
Huh?
Never had an example in the lung of that.
Yeah.
I saw it in
the liver, Irene?
In the liver.
You do?
I saw it once in the liver.
Hydatid disease?
Sorry?
No, I'm asking Matt, do you see it in Canada?
Yeah, I've actually had a number of these cases in the lung. Had one in the kidney where the patient actually presented with hydatiduria. They were actually passing some of these little cystic structures that, and they thought it was just like bubbles, but it was actually these little pieces of the hydatid cyst, and they call it hydatiduria.
Wow.
And Dr. Pritt, when I was at Mayo, taught me that sometimes patients can actually cough these up. And apparently they taste salty when they get coughed up. And so the other way that they can present is coughing up this salty tasting material. that's you can cough up these hydatid cysts.
Wow, that's bizarre.
Yeah.
I have to say that I've only seen one hydatid in the lung in like however 14 years of practice here in the US. But in India, when I was a resident, this was like every day
Okay.
or every week you would get one case.
Wow.
Not in the lung, usually in the liver and in some other locations. But this was so common in India. And
The piece of trivia: did you know that the hooklets are actually AFB positive?
yes.
So if you and they're like brightly positive on an AFB stain. So if you ever see brightly positive things, that can be a trick.
Correct. It's the main utility of that trivia is to torture residents.
It is, yeah.
and look, really, when the residents are getting all the answers right, that's the one to pull out. You're like, all right. So great job on this one, guys. Let's go to this one. So this patient, I'm going to use that annotate thing here because there's I can do that, right?
Yeah.
So that people can see what we're talking about.
Ground glass opacity.
Yes, this patient was being followed in a smoking cessation low dose CT screening program.
Cool.
And was found to have a 1.1 centimeter ground glass opacity. When this ground glass opacity was resected, which it has been here, it was very difficult to see, but could be palpated. But you can see it here. It forms an undefined lesion. And when it was examined on H&E, was found to be completely lipidic, 100% lipidic and non-mucinous. What is the diagnosis? By the way, the entire lesion was submitted, so everything was submitted for histology. Yay! Adenocarcinoma in situ. So both of you got it right. So this is, I think one of the few really nice pictures I've seen of a gross appearance of a adenocarcinoma in situ. Just is so ill-defined. If I didn't circle it, it might be even difficult to see. And sometimes our clinicians will put a fiducial in it, like a little thing like you put for a breast lesion, so that they can actually figure out where to resect because they can't feel it,
Mm-hmm.
So then they bring it to us and they say, well, do you see the lesion? And it's very difficult to find. So I find like palpating it is sometimes easier because you can feel the little firmness. It's one of those few times where a lung pathologist's gross skills become very important. Like what a small lipidic lesion feels like and looks like.
Definitely.
They don't use that. These harpoons or these needles, they put something that helps them to see it, and they sent me one like that, and I was so proud because I found it just by slicing, but then it turned to be papillar. It looked just like that, but it was full papillar, and I think papillary can look ground glass also.
Yes, absolutely. I've even seen micropapillary that looks ground glass like that. So absolutely, that's true. Just because something is lipidic radiologically doesn't mean that it will necessarily, that is ground glass radiologically doesn't mean it will be lipidic pathologically.
The correlation is not that perfect.
No, it's not perfect. Like in everything else in pathology.
I have a really nice example of a minimally invasive adenocarcinoma gross.
Really?
Yeah, here. Do you mind if I quickly show that? And
actually, we do one on these lesions.
Yeah, let me just.
Okay, let's see. Can we move to the?
Yeah. Can you see that there?
Yeah. Oh wow.
So same thing. There's the largely lipidic, and then see there's that little tiny. I can circle here, a little dot right there.
Yeah.
So that actually turned out to be a little invasive component to it.
Interesting.
Yeah.
Beautiful picture. Yeah.
This is the nice example, the one where you have you can measure the part. But I've seen sometimes that you have some acinar here, some acinar here, some acinar here.
All right. Here is a. Okay, let me frame the question like this. This is a 35-year-old patient with long-standing severe asthma now has a lesion that is filling up a bronchus. The clinician thought that it was a mucus plug and they removed it. And this is what we see on the H&E. What stain would you like to see next?
I don't know. Humans. Oh. I don't know. I haven't seen the.
Like, those are all charcoal-laden crystals, right?
Yeah, charcoal-laden crystals.
I was just looking at the crystals and.
Because there's like allergic mucin, right?
Allergic mucin, yeah.
Yeah, so I want to make sure there's no fungus in it.
Eosinophils, and that's the non-eosinophil mucin, and these are the charcoal-laden crystals. So then this patient would have either mucoid impaction of bronchi alone or ABPA, and either way you should get a GMS stain to look for aspergillus and allied fungi like that. So really the main thing is that just the appearance of mucoid impaction of bronchi or allergic mucin. And this is a bit unfair too, because I didn't show the low mag where you would see the, the laminated kind of appearance. Okay, so non-spotter, sorry guys. Okay, let's go to another one. This patient is a 19-year-old boy who, this is this third episode of a pneumothorax. And this finding was seen on the visceral pleura. What is it called? "19-year-old boy, recurrent pneumothorax, and the pneumothorax area was resected with a wedge resection, and this was seen on the visceral pleura."
I'm out of sticky notes.
Let Irene go first. Let's see. HCC.
No, it's Langerhans. No, sorry, LCH.
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 Okay.
I still haven't found the cells, but I imagine.
Yeah. That's actually the clue, Irene.
Yeah, I'd be worried about that as well. So I'd do a CD1A, but I think sometimes you can get these eosinophils just as like a reactive thing to the pneumothorax, right? Reaction to
I think so. But some of these cells look big. I would like to look carefully to them if it have the groups or.
Yes. So you guys bring up actually the differential diagnosis, which is Langerhans cell histiocytosis, but this is actually reactive eosinophilic pleuritis. Yeah. It's just a reaction in the pleura to pneumothorax. Extremely common. Virtually every pneumothorax case has it.
I was driven by your like for histiocytosis.
Yeah, I know what the clue is there, and of course I'm not showing you, right? You don't have the whole case. The clue is that it's only on the pleura. There's nothing in the lung.
Yeah,
the lung is completely normal. This reaction is only in the visceral pleura, and that's very, very. So in these cases, I don't even stain it because it would make no sense for LCH. This is just such a common finding in pneumothorax cases. All right, and we're back to your favorites.
He threw us some biopsies, but they say they are not guessing the biopsies needed. Let's go back to cytology. Let's go.
Okay.
This patient, let's make up where he lives. This patient lives in the
Ohio River Valley.
Yeah, lives in Columbus, Ohio. Let's put it close to the Ohio River Valley.
That doesn't help.
Ohio River Valley presented with fever for 2 weeks duration. He was treated with antibiotics but had no response. Interestingly, he is taking infliximab for rheumatoid arthritis, so he's immunocompromised. On his initial lab test, he was found to be severely anemic and thrombocytopenic, and was found to have also bilateral diffuse ground glass opacities in the lung, hyaluradenopathy, and elevated liver function tests, and now has this finding. Diagnosis?
Oh, no.
Is it histo?
Oh,
Irene?
could be. I didn't thought about that.
So, you know, that's where the stem is leading with the patient in the Ohio River Valley, lots of infection-related symptoms. And then everything I described in the stem is basically classic disseminated histoplasmosis. So really immunocompromised patient, infliximab is actually very notorious for causing severe reduction in cell-mediated immunity. And then this is a really huge macrophage, right? With these dots in it.
Is the histo.
Right? So if I give you a different stem, let's say I told you this is an Indian patient and these are lesions in the spleen, you should be thinking then disseminated leishmaniasis, right? You would be thinking leishmania. But in the stem I gave you, this is virtually always disseminated histo. And of course, the one stain you want to confirm it is a GMS. Once you get the GMS stain, this is basically diagnostic. Okay.
And if
Histo's
it's
pretty.
Yeah.
If it's an Indian patient that is visiting river.
Yeah. This is an Indian patient who lives in Columbus. The pixel is wider.
Histo's pretty uncommon in Spain, right, Irene?
Yes. I had one case. And actually it was because it was a patient that was not from that was from Latin America or someplace, and it was very hard to diagnose. I said it was that, but the story was very well. It was very hard to diagnose that case.
Yeah, this is the story with endemic infections, right? Like for one person, that could be your daily bread and butter. For the other person, it's like I've never seen this, or like it's like seen one case in my life. Same for in India, for example, where I was a resident, leprosy was daily cases. You know, in my thing, we would get 5 or 6 cases of skin leprosy every day in our daily scans. I've never seen one since then. You know, I've never seen one. I used to get cysticercus every week, not disseminated, but some form of leishmaniasis every week. All that stuff I don't see here at all. You know, it's just. That's why I love cryptococcosis. By the way, guys, that's why I made that huge tutorial on cryptococcosis, because that's one thing you will see in every part of the world, right? Everybody sees cryptococcus everywhere. Isn't that correct? Do you guys see crypto, right?
I don't get much biopsies of infections. I don't know why, but I don't get much. I love to see these tweets because I don't get much of these biopsies. I see more TB or tuberculosis, but when I see fungus, it's very I have it in my archive because I'm so happy when I see this yeast or.
Yep.
Cool.
All right, I think we're coming to the end. Here's a patient with a.
I just love Movat. I neither have Movat.
Yes, Movat is such a beautiful stain. This is the Movat pentachrome stain, and this patient had a. I don't know, it looks like a big biopsy. Must be a cryobiopsy.
Yeah.
Cryobiopsy for a bilateral interstitial infiltrates. What is your diagnosis?
Sorry, I wasn't writing.
All right, it is, wait for Irene's. OP, all right, organic pneumonia. Look at this. Interstitial lung disease pathologists immediately diagnose thing and are much more hesitant about cytology specimen. It's really a sign of our times, right? Of subspecialization.
Sorry, I should say OP pattern, I guess, right?
OP pattern.
I will get you started.
I don't even make any diagnosis without looking at the CT. So
yeah, I love the OP on Movat. I think it's absolutely
it's so
great.
beautiful. And look at all the things that you described. Who showed the OP? Both of you did, or?
Oh, just Irene.
Irene, right? Just all the things you described, Irene, are seen here, right? the various shapes, the
The
clustering,
dancing plugs of fibroblasts, right?
dancing plugs of fibroblasts, everything is, and the close proximity to a bronchovascular bundle,
Yeah.
all of it.
So cool.
All right, which brings us to this patient.
Getting hungry for some salad.
This patient is lives in Barcelona.
But Irene doesn't get his biopsy neither.
This patient is a 51-year-old man who lives in Barcelona and had a heart transplant 5 years ago and is severely immunosuppressed. Now he comes with a 2.5 centimeter spiculated lung nodule.
I got the crouton giant cell. And
All right.
Cryptococcus.
This is Cryptococcus with the.
My handwriting is getting worse and worse with the excitement. With the excitement.
I want to explain. I want to hear from both of you why this is Cryptococcus.
Because you see holes anytime. You said if you have to take one lesson from this talk, is when you see holes. No.
Yes, holes in the tissue. Yep. Matt, do you want to add anything to this? What makes you think of Cryptococcus when you see an H&E?
That you can really nicely see the cells on the H&E, right? You're not really struggling to see them. They really pop, and that always makes me think of it. And then there's a fair variability in size, right? You have some smaller ones and you have some big ones.
Pleomorphism,
yeah. And so I think that can be a soft sign as well, the pleomorphism size.
Great point. But I'll show you one thing, Irene, just as a side note. See that organism? Like it has a little bit of that helmet shape of pneumocystis. But of course, you would never mistake it for that because all the other things, because of the H&E morphology, you can see it. There's none of the froth with dots kind of thing. And of course, good to remember that this organism also shows narrow base budding, just like histoplasma. All right. This is a tough one. So I'm going to give you one more. This is very, very tough. I'll give you one clue, which hopefully will make it. This is like a zebra, okay? So this is not a spotter for us. So it shouldn't be. So this patient has a very small central lung nodule, like maybe 9 millimeter. 9 millimeter central lung nodule close to a bronchus that was incidentally discovered. Was found to be negative for TTF1 and positive for P63. Interestingly, the patient underwent a sequencing panel and was found to have a EWSR gene rearrangement. So an EWSR gene rearrangement, P63 positive, and a very small central lung lesion. There's no history of malignancy anywhere. Tough, huh?
Yeah.
Definitely not a spotter. Not a spotter. This is like a.
I was thinking about NAT. This NAT, but should be aggressive thing, a big thing, a big problem, not just a nodule.
Should not be. Should not be just a nodule.
Yeah.
But
should not have the EWSR gene rearrangement, right? Should have a NAT fusion.
But maybe I thought you were keeping that part and was EWH with NAT, or because they are seeing now NAT with many things.
Yes. So I'll say here that there are no other surprise findings after this. This is it. The EWSR fusion was diagnostic of this lesion.
I initially thought of salivary gland type things when you
first. Yeah, you're on the right track.
And with the P63, that would be in keeping with it, but I'm not sure which salivary gland has an EWSR.
Yeah,
fusion.
That was actually interesting thing is we just had a PPS case of the month a month or two ago with this lesion. Maybe it wasn't a month or two ago. Maybe within the last year.
Behind on my PPS cases, I guess.
Yeah, PPS case. So this is a clear cell carcinoma, or what used to be called hyalinizing clear cell carcinoma.
Yeah.
Which is not a good case for a spotter because it's exceedingly rare in the lung.
Yeah.
It's very, very rare to have a lung primary hyalinizing clear cell carcinoma. But the teaching point is that the immunophenotype of a hyalinizing clear cell carcinoma is the same as that of squamous cell carcinoma. It's P63 positive, so you can easily go down that too. P63 positive, TTF negative. But the clue is this hyalinized, like salivary gland type stroma. The bland cytology, it does not look, overtly malignant like a squamous cell carcinoma. And then the fusion, the EWSR fusion in this setting is diagnostic.
And it's with ATF1, is that what
Yeah,
it's?
I think that's the partner, yes.
Yeah.
You're right.
Cool.
All right, guys, I think oh wait, how many do we have? 3, 4, 5, oh my God. Okay, let's go quick.
Let's go quick, yeah.
Can we go quick?
Yeah.
AIDS patient with skin lesions and a lung metastasis. The stain shown is HHV8. Quick diagnosis.
Oh, sorry, I had to write.
All right, perfect.
The same.
78-year-old man with bilateral interstitial lung disease, no exposures, lower lobe predominant and peripheral predominant disease on CT. Let's make it easy, guys. UIP, usual interstitial pneumonia. Let's move to the next one. 28-year-old man with a solitary central lung mass. 28-year-old man. All right. Mucoepidermoid from both. Perfect. So these are spotters. 69-year-old male smoker with a large hilar central mass and SIADH, syndrome of inappropriate ADH secretion. Small cell carcinoma. Thank you both.
Got the beautiful RNA butter on the vessels.
Yes, the Azopardi phenomenon.
Yeah.
But we don't have time to discuss that. Azopardi phenomenon. 62-year-old man with a skin lesion that was resected 5 years ago and now has multiple metastases in the lung.
Wow, my handwriting is like horrible.
Melanoma. Thank you. Both of you are right.
There we go.
45-year-old smoker with multiple bilateral lung nodules with cavitation.
This is the P. I missed the P.
Okay.
I never know how to write this entity.
Pulmonary cytosis. Perfect. 45-year-old woman, never smoker, with bilateral ground glass infiltrates and air trapping. HP, hypersensitivity pneumonitis. You see the giant cell, the beautiful interstitial lymphocytosis.
I have to say it.
Yes.
Matt waited until the air trapping. I saw him. He waited until the air trapping.
Well, yeah. I guess the one thing I was thinking is could this be sarcoid?
I was thinking the
right?
same.
And I was like, I didn't want to, because I guess this could be sarcoid, right?
Right. It could.
The granuloma could be sarcoid, but I thought the interstitium was inflamed.
Yeah, inflamed,
Yeah.
which would be less in keeping with that.
Yeah, it would be unusual to get interstitial inflammation. Also, bilateral ground glass opacities is rare in sarcoid. But yeah, you're absolutely right, Matt.
I was just kidding.
But we are trying to trick you. Okay, here's a non-lung case, but rarely can be seen in the lung. This patient has HIV/AIDS with extremely low CD4 count and has brain lesions.
Oh, my pen.
Oh yes. Again, Irene beats Matt to the draw.
You win.
Yes, this is toxoplasmosis, and really, this is actually from the brain.
Cool.
This is a case that we had many years ago, and was diagnostic just on the H&E. Toxoplasma was also confirmed later by immunohistochemistry. Actually, the clinical impression in this case was immune reconstitution syndrome. That's what they thought it was.
Wow.
And I'm like, no, that's the opposite of immune reconstitution syndrome. This is immune deficiency syndrome with an infection. Yeah. All right. This patient has
beautiful.
A history of cystic fibrosis with bronchiectasis, and this lesion was seen inside one of the bronchi.
I wrote fruiting
Sorry.
bodies and aspergillus.
Bodies in an aspergilloma.
Aspergillus.
Perfect. Both of you are
Those are beautiful fruiting bodies.
killing it.
Yes.
Yeah, these are beautiful fruiting bodies, or nearly pathognomonic of aspergillus. And then this is a patient with diffuse alveolar damage who was found to have the resident noticed these structures in one area. Is this an organism or not?
Aspiration?
I got you.
Sorry, I'm going to write it again.
Okay.
It's not a,
It's an organism? No.
An organism or not? That's all you have to say. Yes or no?
no.
No.
No. Okay.
Yeah.
Both of you are right. This is actually Mallory Hyalin.
Oh, nice.
Oh, I thought it was this cross-povidone
Yeah, me too.
thing.
But
I've written cross-povidone.
Inside the cells. See, it's inside the pneumocyte.
Oh, yeah.
I didn't. I don't see it well, but I've seen this in the pneumocytes.
Yes, in the pneumocyte.
Some places it's written that that has been associated to UAP.
Can be seen in UIP too, especially if there's superimposed acute lung injury. But the most common setting is DAD, and the material, this material is ubiquitin intermediate.
Like in
the liver.
Yeah, like in the liver. Mallory Hyalin or Mallory Denk, I think some people call it. Interesting.
The cross-povidone would be blue.
COVID. So in COVID cases, these are called COVID inclusions.
Yes. And megakaryocytes are COVID cells.
Yeah, megakaryocytes are responsible for all the thrombotic events in COVID. Oh man, it is a fun time to be a lung pathologist. And read the
exciting time.
All right, guys, this patient is an immunocompromised individual with brain lesions and lung lesions. Interestingly, a smear was performed at the time of this biopsy, and the smear is reported as being AFB positive.
So this is an AFB stain?
This is actually GMS.
Okay.
But a smear, so this is GMS on the biopsy, but AFB on the smear was positive. Hey, show it again. I think
Not the spaghetti, the meatball and spaghetti image.
Could be. That is definitely in the differential but why would it be AFB positive on the smear?
That's why I pulled it when I heard you.
Is it a tinal? I don't know how big this is. I'm struggling with the size of this.
It's very, very, very slender and small, but long.
So these are more like filamentous bacteria.
Yes.
I don't know,
It's almost impossible that this will show up on the boards because they like to show this in an AFB stain, not on a GMS stain. This is actually nocardia.
Nocardia, yeah.
Oh, that's
nocardia. And the thing that I keep, reminding people on Twitter, and actually wherever I've presented this, people agree with me, that in tissue specimens, so formalin-fixed paraffin-embedded histology specimens, GMS is a much better stain for nocardia than AFB is. It almost never stains with AFB. But in microbiology and on cytology specimens, like sort of fresh, unfixed specimens, these things are AFB positive.
Cool.
So very helpful to know. An AFB positive thing in a brain, you should be thinking of nocardia always.